get right to it. We have limited time. Very early on during COVID, you were sounding the alarm over the lack of early intervention, early treatment protocols. What was deficient with the existing care?
Our CDC and our government agencies failed to realize that we must apply early treatment in a community standard of care in order to avoid hospitalization and death. And now, nearly 3 years later in the United States, our CDC agrees we should start with early care. But the approach really needs to involve multiple interventions and not a single drug. And I'm convinced of this 3 years into it. I've been treating patients. Doctors in my circles have treated thousands, if not hundreds of thousands, millions of patients worldwide. We need to use drugs in combination. Any one of the currently published protocols, McCullough protocol, FLCC, and others, they're perfectly fine. They'll help people get through the illness.
So was there a willingness in your experience among hospitals to evolve the treatments as they learned more? I mean, the whole point during COVID was, oh, we don't know enough. But as data started coming through, there were new, as you mentioned, protocols coming to surface. Was there a willingness to evolve those treatments?
Almost all the innovation was in the outpatient arena. So pre-hospital care, that's where the innovative protocols came from. They came from all over the world. Inside the hospital, there was relatively little innovation. Hospitals stuck to government protocols without exception. We never saw the Harvard protocol or Mayo Clinic or Duke protocol. And the in-hospital treatments were very minimalistic. Many hospitals in the United States featured remdesivir, which the WHO said not to use in November of 2020 because it doesn't improve mortality, can just cause complications. The WHO has stood by that recommendation. Analysis in Lancet in May of 2022 showed the same thing, no mortality benefit with remdesivir. And we just didn't see the advancements in the inpatient side as we did as the outpatient side, and no comparative statistics. No hospital stepped up and became centers of excellence. There was no comparative mortality statistics across provinces, states. And so in-hospital care was really not well received by the public, disappointed.
So why do you think that was? Why do you think there wasn't seem to be a willingness to accept these new protocols? Why?
The COVID relief countermeasures came from the governments down to hospitals. And I think they really put a chill on any form of hospital innovation. It comes from the governments down to the hospitals. This is the first time that hospitals and doctors were really told how to treat patients, and it was a disaster.
Well, I know in Canada, for example, about, I guess 2 decades ago now, we were dealing really with the SARS crisis when that hit. One hopes we learn from those tragedies, those disasters, that there would be these protocols in place 2 decades later. It didn't seem that anything was executed.
We should have had almost a competition on which hospital could do the best, which hospital could be innovative. There was a great innovative study in Florida called the ICON study, and it clearly demonstrated that ivermectin, an oral available drug used appropriately off its original advertising label, dramatically reduced mortality. And in the United States, that result was ignored. In fact, ivermectin was advised against its use by the FDA, NIH, and other entities. Yet ivermectin in other countries, about 36 countries, it's first line. So we saw this chasm between from country to region on various drugs, as opposed to an all-out effort to do everything to help patients.
I want to talk a little bit more about those drugs you mentioned and how they were not employed, perhaps even here in Canada. When we come back from this commercial break, please stick around.